I started my talk with some historical background that in the 50s we had just 2 active anti-myeloma agents, and when you want to combine drugs in that era, in fact there was only one combination possible, and that is melphalan with prednisone, which was compared by Professor Alexanian from MD Anderson with melphalan alone, and he showed a 6-month survival advantage. And from then on, people have been evaluating combinations in multiple myeloma. In the 80s there were 4 drugs, and you had to think a little bit more about which drugs you are going to combine. And one of the triplets that was emerging from the 80s was VAD, vincristine, adriamycin, dexamethasone, which was commonly used by then. And now, in 2017, we have so many active drugs that we really need new strategies to pick the best drugs for our patients, the best combinations for our patients. Because when you are going to do this in an empiric fashion, so make all the combinations, test them in patients, that will take not only a lot of time, but you will also expose patients maybe to very toxic or very antagonistic combinations. So we really need new approaches to pick the best combination. And many people in laboratories, also in our own laboratory, are working on finding better combination therapies. And people do that, amongst others, by studying the mechanism of action of a single agent, by looking at the mechanism of resistance of drugs, and then you can choose drugs with different modes of activity, different mechanisms of resistance, non-cross, and also agents that are not additive in terms of toxicity. And then you can really pick good combinations and then subsequently test them in the clinical setting. And hopefully in that way you can improve myeloma care, improve the outcome of patients without increasing toxicity for these patients. I discussed also in my talk that there are certain limitations of this approach, because the laboratory is always a simplification of what's happening in the patient. So often cell lines are used and not primary materials. Often tumor cells are studied, but not in combination with the different components of the microenvironment, which are very important in terms of resistance. Often immune cells are not added in the laboratory. And of course, myeloma is a very heterogeneous disease, and tumors differ from patient to patient. So there are many limitations which you have to take into account, and which we have to tackle, and which we have to work on. But nonetheless, this approach is quite successful, and I showed some examples of very good combinations with a very strong preclinical rationale. And among the combinations that I discussed were some combinations from our own laboratory. We worked, for example, a lot on combinations with CD38 targeting antibodies. And one of the combinations that we evaluated in our lab was the combination of daratumumab with an IMiD, an immunomodulatory agent. And we showed that IMiDs increase ADCC, antibody-dependent cellular cytotoxicity, induced by daratumumab, that they improve the immunomodulatory effects of daratumumab, that they increase the direct effects of CD38 antibodies. And this strong preclinical rationale translated in the end to very good results in the POLLUX study, in which there was a huge progression-free survival advantage for Dara plus Lendex as compared to Lendex alone. And this example shows you how laboratory experiments can clearly guide you in making a good combination for patients, which is effective but also well tolerated. I also showed an example of a combination of an IMiD and a proteasome inhibitor, which, when you look at the mechanisms of action of these drugs, might not be as effective as we see in our patients. So that's another example of a limitation of the preclinical testing as a first step before going to the clinic. So you always have to be critical, you have to think, you have to work in the lab, you have to work in mice, and then you have to see in the patients in trials whether you really can make a step forward or not. We really have to look not only at efficacy, at adverse events, but also at quality of life aspects, how patients feel, are they tired or not tired, what can they do, is their quality of life improving or stabilizing. So we are typically adding all these aspects that you mentioned in our clinical studies, both in the elderly patients but also in the younger patients, because I think that's a very important aspect. Because when you are improving progression-free survival with a very bad quality of life, I think you're not doing the right thing.